Thank you so much for your time today. My name is Dr. Julie Master. I'm a cardiologist at Monmouth Medical Center. Today, I will discuss pregnancy and heart disease. Your heart doesn't beat just for you, and this is especially true of pregnant mothers. During pregnancy, the heart needs to work twice as hard to nourish the needs of the growing baby. Pregnancy can be looked at as a stress test on a woman's heart. Cardiovascular disease have been considered a disease of men. It has been understudied, underdiagnosed, and undertreated in women. Prior to 1986, women's health issues, except reproduction, received little attention and research funding. National Institute of Health had no policy about inclusion of women in large trials addressing heart disease, cancer, and stroke. They did not even include female rats. In 1986, NIH established policy requiring researchers to state if women were included in a study, and if not, why. Often labeled a silent killer, heart disease is the leading cause of death in the United States in women, killing 1 in 3. Yet only 56% of women are aware of the fact. They're also not aware that 80% of deaths are preventable. To debunk the myth that heart disease is just a man's disease, in 2004, the American Heart Association created Go Red for Women campaign. It is a social initiative aimed at spreading awareness of heart disease in women so that women know that they can be at risk too. Cardiovascular disease does not just affect older women. Each year, more than 30,000 women less than 55 years of age are hospitalized with heart attack in the United States. The substantial decline in event rates and deaths in the United States seen in the past decade is absent in young women. We're seeing troubling trends of worse risk factor profiles and higher mortality among younger compared with older women and men. Mortality rates for women aged 35 to 44 are annually increasing. Women do much worse than men after cardiac event. At both 5 and 10 years after myocardial infarction, more women die within a year, 26 compared to 19% of men. Within 5 years, 47% of women compared to 36% of men. More women with heart attack have longer hospitalizations and higher in-hospital deaths, and they manifest more complications and endure more readmissions in 30 days. There's a big fat yawning gap between cardiovascular diagnostic testing and resulting medical treatments, depending on whether doctors are looking at a male or female patient lying there in front of them on a gurney. Dr. Healy coined the phrase Yentl syndrome in 1991 in her article published in the New England Journal of Medicine. Yentl, the 19th century heroine in a singer's short story, had to disguise herself as a man to attend school and study the Talmud. Being just like a man has historically been the price that we had to pay for equality. This healthcare inequality includes cardiology. New England Journal of Medicine editorial in the same issue highlighted discrimination against women in cardiology, including the reality that women hospitalized for heart attack are less likely to be treated with guideline-directed medical therapies. But New England Journal editorial was written in 1991. Surely the things have improved for women since then, but not so fast. Over 20 years later, Dr. Merce wrote her own article in European Heart Journal observing that the Yentl syndrome is alive and well. Studies continue to demonstrate undertreatment of women compared to men. We do a worse job of recognizing and predicting cardiovascular disease in women than in men, in part because it presents itself so differently between the sexes. Many preventive efforts start way too late to be effective. There has been a call for primordial prevention, or prevention of cardiovascular risk factors themselves. Recent literature has suggested that otherwise healthy woman who is unable to carry her baby full term has experienced an abnormal physiologic stress test. There are changes that occur in woman's body during pregnancy. Her blood volume and red cell mass increase, leading to increased work of the heart. Those gradual increases in blood pressure, heart rate, and cardiac output over the months of pregnancy are in some ways similar to acute responses that we observe during exercise stress testing. A reversal can be seen as early as 2 weeks after delivery, again comparable to those cardiovascular changes seen during recovery period of exercise stress test. Hypothetically, the pregnancy response may serve as a window into future cardiovascular risk. If we are to prevent cardiovascular disease in women, then early evaluation and treatment of pregnancy complications provides an important window to implement preventive efforts which may delay or even alleviate cardiovascular complications later in life. On average, more than 80% of women in high-income countries bear at least one child, as do upwards of 90% of women in most lower and middle-income nations. A high proportion of women in the course of their reproductive career will have a pregnancy complication either by diabetes, high blood pressure, or small or large baby. Each of those complications have been associated with roughly twofold increase in the risk of cardiovascular events in the future. So 30% of pregnant women carry potent cardiovascular risk predictor. Pregnancy should not be considered an isolated life event, but as part of the continuum. We all know, hopefully, traditional risk factors for heart disease such as diabetes, smoking, obesity, physical inactivity, hypertension, and high cholesterol. But there are emerging non-traditional risk factors that we recognize play an important role, such as preterm delivery, having high blood pressure during pregnancy, having diabetes during pregnancy, also autoimmune disease, breast cancer treatments, and depression play an important role. Cardiovascular disease has been estimated to be present in about 1 to 4% of pregnancies. Although heart disease complicates very small amount of them, it has become a leading cause of maternal morbidity and mortality. It surpasses both hemorrhage and embolic events. One of the most significant accomplishments of modern medicine worldwide is the dramatic decrease in neonatal mortality, or babies dying after birth, in the past 20 years. In most of the world, maternal mortality is decreasing as well. United States is the only developed nation with the rising maternal mortality. It has increased from 7 deaths per 100,000 in 1989 to over 27 deaths per 100,000 as recently reported. Maternal mortality is even higher for Black women, approaching fourfold of their white, Asian, or Hispanic counterparts. So how do we explain rise in maternal mortality? Likely contributing to increasing mortality is that women choose to have children later in life. Aging mothers have high burden of cardiac risk factors. In the United States from 1976 to 1986, the rate of first births among women 40 years of age or older has doubled. In this slide, I summarize for you risk factors in United States women over the age of 20, and those numbers are striking. 30% of us have high blood pressure, 40% of us have high cholesterol, over 10% are diabetic, 27% are pre-diabetic, 13% still smoke, and over half are inactive. It's striking that 80% of African American women are either obese or overweight. During pregnancy, changes occur to the heart and blood vessels. Those changes put extra stress on a woman's body and require the heart to work harder. They help to ensure that your baby will get enough oxygen and nutrients. During first trimester, the amount of blood pumped by your heart increases by about 40 to 50% and remains high during pregnancy. Cardiac output refers to the amount of blood pumped by your heart each minute. During pregnancy, the output increases by about 40% because of the increase in blood volume. It's normal for your heart to increase its heart rate by 10 to 15 beats per minute during pregnancy. Blood pressure usually drops. It's due to hormone changes. Most of the time, the decrease in blood pressure does not cause symptoms. Your doctor will check your blood pressure during your prenatal appointments and will let you know if your blood pressure changes are the cause of concern. Those changes, however, even in normal pregnancy can cause you to feel fatigue or short of breath or lightheaded. All of those symptoms are normal. However, in some women, they can be significant. Talk to your doctor if you have any significant symptoms. Most moms won't have any trouble at all, but some moms, especially older moms who already have heart disease, are at higher risk for developing heart problems when pregnant. You are at higher risk if you had complications such as preeclampsia during past pregnancies, if you're over 40 years old, have high blood pressure, diabetes, or are obese. Unfortunately, African American women have 4 times greater risk of developing cardiac complications during or after pregnancy. We can be proactive. Before you get pregnant, it is very important that you discuss with your obstetrical team whether you had any complications during previous pregnancies, whether you have any pre-existing conditions such as diabetes, high blood pressure. Make sure it's okay for you to become pregnant and ensure that those conditions are well managed before. The American Heart Association recommends scheduling a pre-pregnancy evaluation with your doctor to discuss any concerns you may have regarding pregnancy and heart disease. Blood pressure levels are incredibly important during pregnancy. If you have high blood pressure going into pregnancy, talk to your doctor and devise a plan for lowering it through diet and exercise. Book an appointment with your doctor to discuss any medications that you may be taking. Some of them can be dangerous for mothers and babies during pregnancy. If you have a heart condition, such as those listed here, you should be evaluated by a cardiologist and an obstetrician who specializes in a high-risk pregnancy before you start planning it. Cardiology consultation is strongly recommended before or during pregnancy if mother has prior history of heart disease. Cardiologists will review your health history, perform a physical exam, and order diagnostic testing to check your heart function and severity and extent of your heart condition. After reviewing test results, they will talk to you about how safe it is for you to become pregnant and the risk of complications during pregnancy, including potential short as well as long-term risks to you and your baby. They can tell you about any medications or other treatments that you may need before pregnancy. Be sure to discuss any medicines that you take, even the over-the-counter medications, with your doctor. Some of them may not be safe during pregnancy. By preparing for pregnancy and following up regularly with your doctor, most women with a heart condition can safely become pregnant and have a healthy baby. During pregnancy, women should develop a healthy eating plan. Exercise regularly, try to manage stress, and try to get enough sleep if possible. When you deliver your baby, try to continue those things, as well as work towards getting to your goal weight and avoid smoking and alcohol use. Cardiovascular disorders may develop during pregnancy. Peripartum cardiomyopathy is a rare condition. It is when heart failure develops in the last month of pregnancy or within 5 months after delivery. The cause remains unknown. Certain patients, including those with multiple pregnancies or of African descent, are at higher risk. Women with peripartum cardiomyopathy develop symptoms of heart failure, such as swelling in their feet, shortness of breath, or inability to lie flat. After pregnancy, the heart usually returns to its normal function, but some women continue to have problems. Women with peripartum cardiomyopathy has increased risk of complications during future pregnancies, especially if the heart remains weak. About 6 to 8% of women develop high blood pressure during pregnancy. It is called pregnancy-induced hypertension. It is related to preeclampsia, ataxemia, or ataxemia of pregnancy. Symptoms of hypertension include swelling in your feet due to fluid retention and sometimes protein in your urine. Pregnancy-induced hypertension can be harmful to the mother and the baby. Heart attack is fortunately very rare, but potentially deadly complication of pregnancy or a few months after pregnancy. A heart attack can be caused by many things. Patients with coronary disease or hardening of the arteries can have myocardial infarction if the plaque inside their arteries ruptures. The problem is becoming more common since many women wait until later in life to become pregnant. Other causes of heart attack include spontaneous blood clot inside the coronary vessel because pregnancy increases the risk of blood clots, and coronary dissection, or a weakening of the blood vessel wall that leads to spontaneous rupture or tear or clot formation. If you have a heart attack, it's very important for you to get emergency help. Heart murmur can develop during pregnancy because there is increased blood flow through your heart. Murmur is a sound that the doctor hears when they listen to you. Most of the heart murmurs are benign during pregnancy, but sometimes it can be a sign of heart condition. Arrhythmias are irregular or fast heartbeats that women can develop during pregnancy. It is due to hormone changes. Some arrhythmias, however, can cause symptoms. Discuss with your doctor if you're feeling that your heart is skipping a beat or beating too fast. Pregnant women should look out for extreme symptoms such as severe or sudden swelling, feeling faint, severe fatigue, chest pain, or extremely fast heartbeat, inability to lie flat, or severe shortness of breath. Milder versions of those symptoms can be a normal part of late pregnancy, but severe symptoms may be a sign of cardiac condition. Women should immediately contact their doctor or go to emergency department if they experience any of those severe symptoms. If you have any of those symptoms and they don't go away, contact your doctor right away. Describe your symptoms clearly. If your symptoms arise postpartum, be sure to tell your doctor that you recently had a baby. If the doctor tells you your symptoms are normal, ask which symptoms should cause you to call or come back. Go to emergency department if you have persistent or severe symptoms such as chest pain, shortness of breath, or otherwise you feel extremely sick. Make sure you take somebody with you to the emergency department. If you had complications such as high blood pressure during pregnancy, you're at high risk for heart disease in the future, and it's important to have a checkup regularly. If you had preeclampsia, you have 2 times the risk of having heart muscle damage or a blood clot, and 4 times the risk of developing high blood pressure later in life. If you had gestational diabetes during pregnancy, remember you're at higher risk developing diabetes later in life. And it's very important to have regular checkups with your doctor so they can check your sugar every year. If you delivered your baby prematurely or before your 37th week of pregnancy, you may be at higher risk of heart disease in the future. Women with preterm birth and preeclampsia have almost 10 times higher chance of death from heart disease in the future. If you had complications in pregnancy, you can lower your risk of heart disease in the future. See your doctor soon after the delivery. Discuss your pregnancy and any complications you experience. Make sure you get a copy of your pregnancy and post-delivery medical records. Try to breastfeed your baby as long as possible, as it can lower your risk of heart disease. Remember, it's a myth that all pregnancy-related high blood pressure and diabetes complications go away after your baby is born. Remember to get annual checkup with your doctor. At each visit, Your doctor will check your numbers and make sure you know what those numbers mean, such as your blood pressure, your total cholesterol, your sugar, your BMI. Eat healthy, maintain a healthy body weight, try to stay active, exercising at least 30 minutes per day. Try to stop smoking and take your medications as directed. Together, we can prevent heart disease in women. Thank you for your time today.